Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for very high impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very precious and useful tips which may prove very handy in your line of duty. So I welcome you all to part 107 of our Pharmacotherapy MCQ series, Measuring in Infectious Diseases. Welcome. The first question reads, Mrs. ASG, a 55-year-old female patient, presents to your accident and emergency department with a chief complaint of 3 days of painful urination. She is allergic to cotrimoxazole septrin, and she developed Stevens-Johnson syndrome while taking the same sometime in the past. Today she has an estimated creatinine clearance computed using the Cockcroft-Gault equation of 29 milliliters per minute. So my question to you is, which of the therapeutic options listed below would be the most appropriate for Mrs. ASJ's treatment or case now? Would you opt to treat her with nitrofurantoin or cotrimoxazole septrin or ciprofloxacin, or would you settle for amoxicillin? I'll give you 10 seconds to choose the correct answer. I would settle for C, ciprofloxacin, and I'll tell you why. The fluoroquinolones should only be used when none of the first-line antimicrobials for uncomplicated cystitis such as this one can be used, and those include fosfomycin, nitrofurantoin, and cotrimoxazole. Now, the IDSA guidelines for uncomplicated cystitis and pyelonephritis state that amoxicillin and ampicillin should not be used for empiric treatment due to their poor efficacy. There are very high levels of resistance, and we know that cotrimoxazole should be avoided in this particular patient because there is a history of SJS. So we would discourage you from rechallenging the same. There would be problems. Now, nitrofurantoin is contraindicated in patients with a creatinine clearance below 60 ml per minute. So that would be the wrong choice in this particular patient. And another challenge is it will not get inadequate concentrations in the urine. The concentrations in urine would be suboptimal, so that would not be sufficient to treat a urinary tract infection. So all those many words disqualify nitrofurantoin, cotrimoxazole, Bactrim, and amoxicillin. Let's move to the next question, please. And the question reads, Mr. P.L.R, a middle-aged male patient, was newly diagnosed with HIV at your hospital. He has been on a highly active antiretroviral therapy regimen for the past 3 months, and he has proved non-adherent. His current labs include a CD4 of 45, a viral load of 33,000, and the toxoplasmosis IgG antibody negative. So my question to you is, which of the OIs listed below does Mr. P.L.R. require prophylaxis for? Does he require prophylaxis for oropharyngeal candidiasis and PJP, Or does he need to do prophylaxis against PJP and MAC? Or does he require prophylaxis for cryptococcal meningitis and toxoplasma encephalitis? Or is it true that primary prophylaxis isn't indicated in Mr. P.L.R's case? I'll give you 10 seconds to choose the correct answer. So this gentleman needs prophylaxis for PJP and MAC, and I'll tell you why. Based on the CD4 count, which is below the 50 cells per mm³ mark, and his non-adherence, Mr. P.L.R. should receive prophylaxis for both PJP, which should usually begin below 200 cells per mm³, and for MAC, which usually begins below the 50 cells per mm³. And you know that he is non-adherence and he has a high viral load. So that makes him qualify to do prophylaxis for those two. Remember, primary prophylaxis for cryptococcal meningitis isn't recommended. We only do secondary prophylaxis. That is after a bout of cryptococcal meningitis. Then I would like to add that primary prophylaxis for toxoplasma encephalitis isn't recommended since the patient is IgG negative. The patient, that is, hasn't been exposed to toxoplasma at all. Then I would like to add that oropharyngeal candidiasis doesn't require primary, neither does it require secondary prophylaxis. Let's move to the next question, please. And it reads, Mr. TML, a 25-year-old male patient, presents to your dermatology clinic with an abscess on his forearm. The physician on duty, the dermatologist that is, successfully does incision and drainage during this clinic visit. Mr. TML hasn't taken any medication in the past 1 year and he has no known drug or food allergies. Today, his temperature is 37 degrees centigrade, he has a heart rate of 66 and a respiratory rate of 20. So my question to you is, which of the therapeutic recommendations listed below would be the most appropriate for Mr. TML now? Would you opt to treat this case with the cotrimoxazole after the incision and drainage, or would you prescribe doxycycline 100 milligrams twice daily, or would you administer clindamycin 300 milligrams thrice a day, or is it true that no antibiotic is indicated or needed in Mr. TML's case? I'll give you 10 seconds to choose the correct answer. So Mr. TML does not require any antibiotic at the moment. Now the IDSA guidelines for skin and soft tissue infections state that only incision and drainage are needed for mild, purulent skin and soft tissue infections such as furuncles and carbuncles and even abscesses. The absence of a systemic inflammatory response syndrome, that is SARS, is used in identifying this patient to have mild, purulent skin and soft tissue infection. I would like to remind you that unnecessary antibiotic use can have several deleterious consequences to such a patient, which may include, for example, selection for resistant bacteria, superinfections. You may have cases of C. diff, associated diarrhea, and there may also be adverse events and even cost increases unnecessarily when you use antibiotics where they are not indicated. Let's move to the next question, please. And it reads, Master FTP, a 5-year-old boy, presents to your pediatric accident and emergency department with clinical signs and symptoms of Group A streptococcal pharyngitis, what we abbreviate as GAS. He has no known drug or food allergies, and you establish there is no significant history known. So my question to you is, which of the therapeutic options listed below would be the most appropriate initial treatment option for Master FTP now? Would you opt to treat him with cotrimoxazole Bactrim, or would you choose minocycline, or would you treat him with amoxicillin, or would you administer ciprofloxacin twice daily? I'll give you 10 seconds to choose the correct answer. I would opt to treat this case of GAS with amoxicillin. Now, the IDSA Group A streptococcal guidelines recommend amoxicillin, which can also be dosed using an OD dosing regimen, but in that case it has to be higher, 50 milligrams per kilo, a maximum of up to 1 gram daily. Now, high rates of tetracycline resistance preclude their use in such patients, and even age does not allow. Then I would like to add that cotrimoxazole doesn't eradicate GAS in acute pharyngitis. I'd like to go back to Cipro and comment that ciprofloxacin has limited activity against GAS pharyngitis and shouldn't be used, especially in the pediatric population, without a proper indication. Avoid it in these children. Then I would like to add that penicillin-resistant GAS hasn't been documented in literature, so I would comfortably treat such a patient using amoxicillin. Let's move to the next question, please. And the next question reads, which of the pathogens listed below is the most common cause of community-acquired native valve endocarditis? Is it the fungi? Is it the aerobic bacteria, the gram-negative bacilli to be specific? Or is it the viridans group streptococci? Or is it the staphylococci? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. Viridans group streptococci are the culprits here. Now the VGS are the most common pathogenic agents in native valve endocarditis. I'd like to remind you that staphylococci are common in prosthetic valve endocarditis, the PVE, within the first year after a valve replacement procedure is done. Aerobic gram-negative bacilli and fungi are very uncommon in these cases of endocarditis. Let's move to the next question, please. And it reads, Miss KWG, a 16-year-old girl, presents to your clinic with a chief complaint of 2 days of worsening fever, sore throat, among other symptoms. On physical examination, we establish she has bilateral tonsillar swelling. She has a past medical history of asthma, and she manages her asthma with PRN salbutamol inhaler. Now you do a rapid strep test at your lab and it turns positive, and you establish that this girl has an allergy to penicillin. The last time she had a penicillin, there was a mild rash. So my question to you is, which of the therapeutic options listed below would be suitable for Miss KWG? Could it be moxifloxacin, clindamycin, cefalexin, or clarithromycin? I'll give you 10 seconds to choose the correct answer. So answers B, C, and D are all correct. The IDSA Group A streptococcal guidelines state that cephalosporins should only be avoided in patients with immediate type 1 anaphylactic type hypersensitivity to penicillins. I'd like to emphasize that clindamycin is also mentioned as a reasonable option for penicillin allergic patients, given that only 1% of GAS isolates are resistant to clindamycin. So clindamycin would be an option. Then clarithromycin is also an option for penicillin allergic patients. Now 10 days of clarithromycin should be administered, and it has been found to be more efficacious than 5 days of azithromycin in one of the studies of GAS pharyngitis that was carried some time back. It's recorded somewhere in literature. I would like to add that moxifloxacin isn't recommended routinely for GAS pharyngitis because it is an expensive option and it has an unnecessarily broad spectrum of activity. Furthermore, Miss KWG is below the age of 18 years. Therefore, moxifloxacin therapy should be avoided unless there aren't any other suitable options. So use it only when it's a last resort. Let's move to the next question, please. And it reads, Mrs. LCM, a 59-year-old female patient, returns home from an overseas trip with a chief complaint of headache, neck stiffness, and fever. A CT brain is done and it was negative. Turns out normal. A lumbar puncture was performed after drawing blood for culture and sensitivity due to concerns for probable meningitis. This lady has no known drug or food allergies. My question to you is, which of the therapeutic regimens listed below would be the most appropriate for Mrs. LCM before her culture and sensitivity results are released by your microbiology lab? Would you choose to co-administer moxifloxacin and vancomycin? Would you settle for ampicillin and gentamicin? Would you choose to administer vancomycin, ceftriaxone, and ampicillin? Or would you settle for cefotaxime and vancomycin? I'll give you 10 seconds to choose the correct answer. In my opinion, ceftriaxone, vancomycin, and ampicillin would be the right regimen there. Now, I would like to start by saying that patients below the age of 1 month or above the age of 50 years should receive empiric ampicillin in addition to standard empiric treatment for suspected bacterial meningitis to cover for the possibility of Listeria monocytogenes being a pathogen in this case. Ceftriaxone is only used for a pediatric patient if that patient is above the age of 1 month, and that is due to the risk of biliary sludge and hyperbilirubinemia that could lead to kernicterus. So remember that. Now for pediatric patients below the age of 1 month, cefotaxime is the preferred choice alongside ampicillin and vancomycin. So remember those fine details. Let's move to the next question, please. And it reads, Mrs. HJL, a 47-year-old female patient, is admitted to your general medical ward with a mild to moderate intra-abdominal infection. She tells the physician she's allergic to azithromycin And when the physician probes further, she says she had diarrhea the last time she took azithromycin. Currently, she takes aspirin, ramipril, and metformin. So my question to you is, which of the therapeutic options listed below would be the most ideal for Mrs. HJL now? Would you settle for meropenem and infuse 2 grams over 3 hours continuously every 8 hours? Or would you settle for doripenem? Or would you administer etapenem? Or would you choose imipenem cilastatin? I'll give you 10 seconds to choose the correct answer. I would opt for etapenem. Now, etapenem, marketed as Invance, is the only carbapenem that is recommended by the IDSA guidelines for mild to moderate intra-abdominal infections. Remember that. Now, doripenem, marketed as Doribex, alongside imipenem, cilastatin, marketed as Tianam or Primaxine, and meropenem, marketed as Meronem or Merem, should all be reserved for patients with more severe intra-abdominal infections. They would not be indicated in a mild case like this one. Let's move to the next question, please. And the next question reads, Mr. TKM, a 58-year-old male patient, is admitted to your general medical ward with a chief complaint of mild to moderate intra-abdominal infection. He has no known drug or food allergies. Currently, he takes amitriptyline for his depression and triazolam to induce sleep. So my question to you is, which of the therapeutic regimens listed below would be the most appropriate for Mr. TKM's case? Would you opt to treat him with cefepime alongside clindamycin? Or would you settle for ceftriaxone and clindamycin? Or would you settle for ceftriaxone and metronidazole? Or would you choose cefepime and metronidazole? I'll give you 10 seconds to choose the correct answer. I would choose ceftriaxone and metronidazole. Now, I would like to start by reminding you that clindamycin is no longer recommended for intra-abdominal infections due to the increasing prevalence of resistance among Bacteroides fragilis isolates. Remember that. So that automatically knocks off alternatives A and B. I would like to emphasize that cefepime is a 4th-generation cephalosporin that is reserved for severely ill patients. So it would not be useful here. It would be too broad. And I would like to emphasize that ceftriaxone plus metronidazole is the best option, or would be the best treatment option for Mr. TKM. Let's move to the next question, please. And it reads, Miss DMN, a 22-month-old girl, presents to your pediatric clinic with a chief complaint of a new onset rash on various parts of her body. The mother noticed them after she took 2 days of the Amoxicillin therapy that was prescribed by the pediatrician for her otitis media. The mother is concerned her baby or her daughter may be allergic to penicillin and wants to inform the pediatrician. Now, according to DMN's medical chart, all her immunizations are up to date. She has a past medical history of G6PD deficiency, which was diagnosed at birth. pediatrician suspects this is an allergic rash and stops the amoxicillin. So my question to you is, which of the therapeutic options listed below would be the most appropriate for the treatment of DMN's unresolved otitis media? Would you settle for moxifloxacin, marketed as Avilox? Would you choose Unacin, which is ampicillin sulbactam? Or would you administer azithromycin, marketed as Zithromax? Or would you settle for cotrimoxazole, Septrin, or Bactrim? I'll give you 10 seconds to choose the correct answer. I would treat these pediatric patients with azithromycin. Now, since DMN has evidence of penicillin allergy, most beta-lactam antibiotics would be excluded from her regimen. And that eliminates Unacin, ampicillin, sulbactam as well. Now, I'd like to emphasize that due to DMN's history of G6PD deficiency, cotrimoxazole is contraindicated due to the risk of hemolytic anemia. I would not risk. Then I would like also to remind you that DMN's patient her age also makes unfit to use a fluoroquinolone. Remember, she's below 18, so it's contraindicated with a few exceptions due to concerns mainly related to tendon rupture. So I would not be too quick to switch to moxifloxacin. I would settle for azithromycin. Let's move to the next question, please. And it reads, which of the antifungal agents listed below requires an acidic pH or medium in the gastrointestinal tract in order for adequate absorption to occur? Is it etazanavir, marketed as Reataz? Is it ciprofloxacin tablets? Is it itraconazole sporanox capsules? Or is it fluconazole diflucan capsules? I'll give you 10 seconds to choose the correct answer. So C, itraconazole sporanox capsules would be the correct answer. Now I would like to start by saying that etazanavir is an antiretroviral protease inhibitor used in the treatment of HIV infection. And ciprofloxacin is a fluoroquinolone antibacterial agent. And itraconazole in capsule form, and not the liquid or IV form, requires an acidic environment in order for adequate absorption to occur. So failure to counsel patients about this can result in loss of efficacy due to insufficient concentrations in the body if we don't pay attention to the pH of the GIT. So those many words make C the correct answer. Let's move to the next question, please. And it reads, your infectious diseases consultant is discussing the causes and treatment of infectious mononucleosis, abbreviated as IM, with a patient at the infectious diseases clinic. The question to you is, which of the statements listed below is true about this condition? Is it true that there is no vaccine to protect against infectious mononucleosis? Or is it true that a person must be vaccinated in childhood to prevent being infected by mononucleosis? Or is it true that the cost of the vaccine for infectious mononucleosis isn't covered by insurance companies in the United States of America? Or is it true that once a person is infected with mononucleosis, the vaccination is most effective? I'll give you 10 seconds to choose the correct answer. So there is no vaccine that protects against IM. I would like to start by saying that a vaccine to prevent what we call the EBV infection was proposed by Epstein and Achong in 1973, a decade after they discovered this human gamma herpes virus. The development of an EBV vaccine has been slow. A single phase 2 trial of an EBV GP350 vaccine has been reported. I would like to emphasize that this vaccine reduced the rate of IM but not virus infection. I would just like to add that EBV is the primary cause of IM and is associated with epithelial cell malignancies such as nasopharyngeal carcinoma, for example, gastric carcinoma, as well as lymphoid malignancies including Hodgkin's lymphoma, Burkitt's lymphoma, and non-Hodgkin's lymphoma, and even post-transplant lymphoproliferative disorder. I'd like to add that EBV vaccine to prevent primary infection or disease or therapeutic vaccines to treat EBV malignancies haven't been licensed. I would also like to add that antiviral drugs haven't significantly impacted the treatment of EBV-related diseases, and treatment of IM is limited to symptomatic treatment, a very tricky medical or clinical condition indeed. It would be a challenge when the patient presents with it at your clinic or hospital. So A is the correct answer there. Let's move to the next question. And the next question reads, Mr. WNP, an 88-year-old male patient, presents or develops osteomyelitis of his right foot due to Pseudomonas aeruginosa. The infectious diseases consultant is treating him with cefepime, and this gentleman WNP refuses to be taken to the operation room for surgical intervention. So my question to you is, which of the therapeutic durations listed below would be the most appropriate for this clinical scenario? That is, for how long would you treat this gentleman using cefepime? Would you do so for 10 weeks, 6 weeks, 15 weeks, or 3 weeks? I'll give you 10 seconds to choose the correct answer. I would treat him for 15 weeks. Now, I'd like to emphasize that more than 90 days of therapy is recommended by the IDSA DM foot guidelines for patients with diabetic mellitus foot osteomyelitis who decline surgery or who have residual dead bone post-operatively. So remember that. Let's move to the next question, please. And the next question reads, Mrs. NVO, a 36-year-old female patient, is admitted to a general medical ward with mild to moderate intra-abdominal infection. She was previously taking doxycycline and orthotricycline as an outpatient. She has no known drug or food allergies. So my question to you is, which of the medications listed below would be the most appropriate for Mrs. NVO's management now? Would you opt to treat her with the piperacillin tazobactam infused at a dose of 4.5 grams over 4 hours 4 times daily? Or would you settle for ertapenem infused over an hour? Or would you treat her with ampicillin sulbactam? Or would you opt for imipenem cilastatin? I'll give you 10 seconds to choose the correct answer. So settle for ertapenem. I'd like to start by saying that ampicillin sulbactam is no longer recommended due to high rates of resistance in community-acquired E. coli isolates. And I would like to emphasize that both imipenem cilastatin and piperacillin tazobactam are reserved for more severe infections. And ertapenem, therefore, is the best choice for Mrs. NVO. Remember, it is also easier to administer. It's administered once daily compared to QID 4 times daily for the other agents. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. If this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it and to share it widely with your peers, and to leave your comments at the bottom of the video. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you all very much for viewing this video and for listening to me. I sincerely appreciate your partnership and your continued support and very kind collaboration. And I look forward to interacting with you in the next video. Thank you very much.